Hi, welcome back to House Healthcare 120, and we are back to 721. We have a new draft in front of us and on our committee page. We have legislative counsel here to walk us through it.
Good afternoon. Ann Kirby, Office of Legislative Counsel. So I will put some language up on the screen. I believe it is also on your website. All right, so this is draft 1.2. Oops, already messing things up. You have not seen a 1.1. So this is the first one you've seen. I just made an edit after the editors had reviewed it. That's why I changed it. So this is an act relating to expanding access to Medicaid and Dr. Dinosaur. The changes are all highlighted in yellow. So some of the ones that you'll see are that I added in the 5% disregard after talking to Diva on the descriptions of the eligibility thresholds, both in existing law and what's being proposed in the bill. So you'll see all the numbers are highlighted, and that's just because I added 5% of what we'd had in the earlier version. But otherwise, there's no changes in the findings. Just quickly pass those. So then we get to section 3. Section 3 in this draft is the DEVA technical analysis. I guess it's really Agency of Human Services, I should say. And it's the technical analysis, and there will be some reports, and putting reports in the heading helps my office track what's coming up. So it directs the Agency of Human Services in collaboration with interested stakeholders to undertake a technical analysis relating to expanding access to Medicaid and Dr. Dinosaur, to rates paid to healthcare providers for delivering services to individuals on those programs, and to the structure of Vermont's health insurance markets. And then I've broken them out. So subsection B is specific to the technical analysis relating to expanding access to Medicaid and Dr. Dinosaur. And it directs the agency to examine the feasibility of, consider the need for one or more federal waivers or one or more amendments to Vermont's global commitment to health, Section 1115 demonstration, or both, or develop a proposed implementation timeline and estimated costs of implementation for, and estimate the programmatic costs of. So just taking away the weird grammar stuff there, look at whether it's feasible, whether we need waivers or changes to our global commitment, whether developing a proposed implementation timeline and estimating the costs of implementing, and the programmatic costs. So costs of implementation would be different from the costs of just what it would take to keep paying for the program on an ongoing basis. Of each of the following. First, of expanding eligibility for Medicaid for adults who are 26 years of age or older, but under 65, so people 26 to 65 and not pregnant, to individuals, expanding eligibility for Medicaid to individuals with incomes at or below 317% of the federal poverty level by 2030. Expanding eligibility for Dr. Dinosaur to all Vermont residents up to 26 years of age with income at or below 317% of the federal poverty level by 2030. Amending Vermont's Medicaid state plan to expand eligibility for Dr. Dinosaur to all residents up to 21 years of age with incomes at or below 317% of the federal poverty level as soon as reasonably practicable. That may be a piece we can do just through our state plan. Expanding eligibility for Dr. Dinosaur to all pregnant individuals with incomes at or below 317% by 2030. Expanding eligibility for the Immigrant Health Insurance Plan. This is what I think Mike Fisher was referring to as IHIP earlier. And this is the one that had started out as Dr. Dinosaur-like coverage. So expanding eligibility for the Immigrant Health Insurance Plan established pursuant to that provision of Title 33 to all individuals up to 65 years of age with incomes up to 370% of the federal poverty level who have an immigration status for which Medicaid or Dr. Dinosaur is not available, and implementing a proposed schedule of sliding scale cost sharing requirements for beneficiaries of the expanded Medicaid, Dr. Dinosaur, and Immigrant Health Insurance Plan programs. I'm going to keep going. Okay. The technical analysis relating to Medicaid provider reimbursement rates would include An analysis of the expected enrollment by proposed expansion population for each of the programs described in subsection B, so that list we just looked at. An examination of the insurance coverage individuals in each proposed expansion population currently has, if any, and the average reimbursement rates under that coverage by provider type. Provider type gets defined. We'll actually scroll down for a second. Provider type, somewhere on here, on page 10, provider type means each category of healthcare provider for which Medicaid maintains a reimbursement methodology, including hospital inpatient services, hospital outpatient services, professional services reimbursed based on the RBRVS fee schedule, and that term is set out in full and then in parentheses up above. Services provided by federally qualified health centers and rural health centers, suppliers of durable medical equipment, prosthetics, orthotics, and supplies, clinical laboratory services, home health services, hospice services, pediatric palliative care services, ambulance services, anesthesia services, dental services, assistive community care services, and applied behavior analysis services. So when we're talking about by provider type, that's the list. So back to page 8, an examination of the insurance coverage that that people in that proposed expansion population currently has, if any, and the average reimbursement rates under that coverage by provider type as a percentage of the Medicare rates for the same services. An analysis of how current Vermont Medicaid rates compare to rates paid to Vermont providers by provider type under Medicare and average commercial health insurance fee schedules. An assessment of how other states' public option and Medicaid buy-in programs set their provider rates, which providers are included, the basis for those rates by provider type, and any available data regarding the impacts of those rates on provider participation and patient access to care. An estimate of the cost to the state by provider type if providers were reimbursed at 125, 145, and 160% of Medicare rates, with both primary care and specialty care services reimbursed under the RBRVS Resource-Based Relative Value Scale fee schedule. If a fee schedule is benchmarked to Medicare rates, how best to structure a methodology that avoids federal Medicare rate cuts while ensuring appropriate inflationary indexing. An estimate of the cost to the state and an analysis of the advantages and disadvantages of benchmarking rates for RBRVS equivalent professional services based on the average commercial health insurance rates paid to Vermont providers rather than the Medicare fee-for-service fee schedule. If rate differentials will continue between primary and specialty care services under the RBRVS fee schedule, an estimate of the costs of including comprehensive prenatal, labor and delivery, postpartum, and psychiatric services under the primary care rate. A proposed methodology for comparing Medicaid home health and pediatric palliative care rates against Medicare home health prospective payment system or Medicare hospice rates. A proposed alternative payment methodology for the FQHCs that sets a percentage greater than 100% of the Medicare FQHC encounter rate as the minimum encounter rate paid to health centers for included Medicaid services, recognizing that DVA must pay FQHCs the Medicaid prospective payment rate, system rate calculated in accordance with Section 1902 BB2 of the Social Security Act, and a proposed process for annually reviewing Vermont Medicaid's reimbursement rates for dental services and evaluating progress toward achieving other recommendations detailed in the report of the Dental Access and Reimbursement Working Group established pursuant to the 2019, the FY20 Budget Act. And there's that definition of provider type. Just skip over that. Then we have the technical analysis relating to the health insurance markets must include determining the potential advantages and disadvantages to individuals, small businesses, and large businesses of modifying Vermont's current health insurance market structure, including the impacts on health insurance premiums and on Vermonters' access to care. Exploring other affordability mechanisms to address the 2026 expiration of federal enhanced cost sharing subsidies for plans issued through the exchange, and examining the feasibility of creating a public option or other mechanism through which otherwise ineligible individuals or employees of small businesses or both could buy into Medicaid coverage. Bill would appropriate $350,000. And this says general fund, but I think from talking to Nolan, there may be some potential for a partial global commitment match here to the Agency of Human Services in FY25 for the technical analysis. And this would have the agency reporting by January 15th, providing its technical analysis to this committee, the Appropriations Committee, and in the Senate, Health and Welfare, Finance, and Appropriations. It specifies that the analysis must include the feasibility of each item described in subsections B through D. So those are all the technical analysis pieces. The federal strategy for achieving each item, including identification of any necessary federal waivers, the process for getting those waivers, and the likelihood that we will be approved for each of those waivers. The costs, both programmatic and the technological and operational costs, a timeline for implementation of each recommended action, and a description of any legislative needs.
Stop there maybe for a second. Questions? I'm doing that because I'm hearing a lot of sighing over here, so I assumed there was a question coming.
Can I ask a question or would you like me to hold that?
You can ask.
I'm not sure it's for Jen.
Well, let's
necessarily.
ask and then we can. decide.
So with provider types, I'm just thinking about what's missing. Skilled nursing facilities.
I think we'll want to hear from Diva. I think that's largely a different set,
Okay.
or different funding streams. So I'm certainly open to additions. There was a list I was working from. I put them on.
And I'm assuming the same thing. Well, we can ask Diva. I'm thinking the same thing for like case ratings, designated agencies.
Yeah, that's completely separate.
Okay. I'll wait till Diva.
All right, and then Leslie.
Yeah, on page 7, item 6, the sliding scale cost sharing. I wanted to understand maybe what that would refer to.
What that would look like, or what that means.
Yeah.
So this is looking at expanding access or expanding eligibility for Medicaid, Dr. Dinosaur, and the Immigrant Health Insurance Plan. And there'd been language in the bill as
The
introduced.
Okay.
Yep,
It
that was
was
gonna,
that.
yes, that was gonna have the agency propose sliding scale cost sharing. Basically, the idea being the more
Okay.
income people have, maybe the more
They can
responsibility they
participate.
might have, right, for some cost share from some.
All right, so that was that.
It was the section you really liked.
Right, yeah. Sliding scale. You got it. Thank you.
Leslie?
I'm good. I'll ask Diva.
Okay.
I'm sorry.
No, it's a process question. Right now, legislative council is reviewing amended language. Is there going to be a point where we can discuss additional amendments or
Yes,
just like evaluate this in the context? All right,
absolutely.
I'll wait then.
Okay, so then we get, oh, sorry,
This may be a very stupid question, but I'm going to ask it anyway.
Did you?
On page 8. The rate that Medicare,
E.
it's on line 8, starts in 16. It's line 8, you go through the 125, 145, 160% of the Medicare rates.
yep.
You just, Medicare rates, what do you mean by that?
So if you start on line 16, an estimate of what it would cost by the state for each provider type. If Vermont Medicaid paid providers at 125% of the Medicare, of what Medicare would pay for the same service. If they paid 145 of the Medicare reimbursement rate, these are all about what the payer is paying the provider for delivering the care.
The Medicare rate is 80/20.
No, that's our federal match, or 80/20 is, no. It's our occasionally our FMAP, but,
Just so, because I'm trying to figure.
oh, what is, well, I think, and the providers will know better. I do think sometimes Medicare may be considered, I think Medicaid is considered 80% of cost, or
right? So Medicare has rates set,
Right.
right? So let's say it's $100 to see your provider or
Yeah.
something.
And then they pay.
We're saying, and this is how we usually do the rates here, is for Medicaid, we want it to be a percentage of what those Medicare rates are. So like last year in our budget, I think it was just last year, we did primary care to 125% of Medicare rates and specialty to like something else. That,
Okay, so you're starting off with 100% and you're going to 125, 45 and 60. Right?
I think there was language in the budget saying reimburse primary care at 100% of Medicare, or tell us why you can't, tell us how much it would cost to do it if you can't. The bill as introduced, I think would do the 125%.
Well, I think I
So
understand.
it's just using Medicare as something that
100%.
gets,
yes.
well, right, as looking at Medicare as something fairly fixed or knowable, that is generally higher than the rates paid under Medicaid, and saying, well, what would it look like if we paid more than the Medicare, this much more than the Medicare rate, as we're potentially moving people from private insurance to Medicaid?
Okay, let me help understand that. Medicare may pay 100%, but it might only be $100.
Correct.
Okay, so we're saying 125% above what they would pay.
Right.
Not above what they would pay,
Above,
of what they would pay.
Of what
So
they would
if they would pay if Medicare would pay $100 for a service, then this is saying, okay, but what if for that service Medicaid paid 125 or $125, $145, $160?
Okay.
What is the out of pocket, what is the cost to the state?
And the providers were looking for this language that, because if we would to move people to Medicaid, providers would be paid less. So to move people, we need to also move up providers.
So the people are actually on Medicaid, but we're paying with Medicaid money, these percentages of Medicare.
This is what we would want to study, correct, of Medicare. But yes, people would be on.
Right, so the patient would be on Medicaid. But
And
this
this is
is
just
about what the
this
provider
is
gets
just a
paid.
baseline to pay from.
Yes, this is looking, right, this is looking at if Medicaid were to pay providers for their services more than Medicaid currently pays for their services.
All right, gotcha.
Medicare would be the benchmark. Right.
Right.
Medicare would be the measure. Correct.
Exactly.
Okay.
But you said something important was that Medicaid reimburses so low that if we owe
Oh, I
it to Med,
understand.
yeah. I thought that was
Well, why
really
don't
key,
we-
actually.
Why don't we tie it into Medicaid and say,
We are Medicaid. So we're
But-
looking,
right, but
we're looking at what if Medicaid rates were, which are usually lower than Medicare. And I think Medicare rates are generally below cost.
right, so why do, but what, and
that's good.
but
It's good.
why don't we take Medicaid and say 200% of Medicaid instead of 126% of Medicare? Why don't we keep it in the Medicaid realm?
Because we need a benchmark amount to be able to raise Medicaid rates.
There's no benchmark of Medicaid?
It's-
Yeah, there is.
There is, but it's very low,
Right. And it's whatever we set it at.
right? Because we're Medicaid.
Okay,
So Medicare is something out of our control, but it's
I'll
public.
trust the
And some would say, some would say
I don't know why, but I'll.
we shouldn't even be using Medicare. We should find another benchmark. So,
Gotcha.
Yep.
I understand it.
All right. We are moving along to section 4. So I'm on page 12. And this is the language that you had looked at that would have the Agency of Human Services reporting on its global commitment investments. And Diva asked you to make some changes. And so this would now say, in addition, still say in addition to its regular report, the agency would provide information. It had been subdivisions A through F, now it's A through E, you'll see why, annually as part of its budget presentation. And the agency may choose to provide the required information for only the subset of the global commitment investments being independently evaluated in any 1 year. Because as you may recall, they have contracted for someone to do analysis of their global commitment investments. And then taking out the language saying you rotate which 20% you're going to look at in any year. And the information to be provided shall include a detailed description of the investment. So this is from the bill as introduced, which Vermonters are served by it, what it costs, what its efficacy is, and then taking out the language about return on investment if applicable, because I believe they said they don't measure, that's not something measurable. So just going down to where in state government the investment is managed, including which division or office is responsible.
And just as a reminder, so these investments is the full list of like 80 investments where money is being spent, and we're just saying we need to look at that money. And they had hired a consultant anyway, so this ties in well.
Sections 5 and 6 deal with the Clinical Utilization Review Board. I think there may be some additional changes coming to section 5. But you may remember this is the one where we had looked at changing who appoints the members of the Clinical Utilization Review Board who are currently appointed by the governor. And I think there were some requests not to change the appointment. So I put it back. That's part of what I'm showing you, is just that I put it back.
Okay.
And then, and still kept in some of the changes just to update the language.
But yeah, we'll be
From implementation. I did leave in on page 15 that the Clinical Utilization Review Board, CURB, would be required to consult with the department's Drug Utilization Review Board. I think they said they do that, but I know that had been important to some people, so it's in here if you want to keep it in here, or you don't have to.
Okay. All right.
Is this section looking at procedures that, actual medical procedures and how they use and when they use? Is that what this?
So we'll look a little bit, go back to the previous page 14 of what this board does. I mean, a lot of it is looking at making recommendations about what Medicaid should cover and not cover,
Okay.
but it's also looking at what gets used a lot, which services get used a lot by beneficiaries. Are these in line with clinical best practices, or has the practice kind of evolved and we should look at covering something in a different way? What are appropriate but underutilized services that maybe people could be taking better advantage of? Things like that.
It has to do with what services we provide Medicaid and looking at the whole realm of those.
Right, what's covered, and I think how it's working, yes, how it's working, whether it's appropriate. It's having practitioner, clinicians involved in advising about what Medicaid covers.
Thank you.
And the intent of these two sections was to make that process more transparent and interactive between the legislature and DEVA. So we had Sandy Hoffman, and if you remember, I've had some conversations with her, and she's working on how to make that happen. This language probably won't get to what the intent was, so we'll come back to that.
But I did add a new section 6, which is there's an existing report requirement for CURB. And so I added that in DEVA's annual report about the results of of CURB's most recent evaluations and a summary of its activities and recommendations, I added including the services reviewed and the coverage decisions made, which I think is starting to get at some of the things we were talking about. But again, there may be more changes to come. I did not make any changes other than a section number change on the Medicare savings programs, which we were talking about this morning. In section 8 on Medicaid state plan amendments, again, some section number changes. And then I added global commitment. So if amendments to this Medicaid state plan or to our global commitment demonstration or both are needed to implement anything else beyond the Medicare savings programs, which we know are a Medicaid state plan item, then they would seek those. And then they took out, we don't really have a lot of times specified at this point. And then finally, we have the effective dates. So it would still take effect on passage, except that section 7, just updating the section numbers, the Medicare savings programs would take effect upon approval of CMS, the amendment to our state.
Questions for Jen on the language? Nope. Thank you, Jen. All right. Alex, so we're going to hear from folks in the room on this latest draft. We'll obviously be doing another draft, because we do have to make some changes to at least that one section. So this is, part of the continual process that we'll be working on for the next couple weeks. Alex.
Thank you, Madam Chair. Thank you, everyone. I'm happy to be here to talk about the latest draft of 721 from DEVA's perspective. I'll caveat this by saying we are still conducting our review of the latest draft, so I will be approaching this from a pretty high-level perspective with you today, and I'm happy to bring follow-ups back to our team and answer everything in more detail when we have that. So I think it might be best for me to just kind of walk through where we flagged from our end.
If you can do a page number and line or row, that'd be great.
Yes, I should be able to. So I'm just going to speak generally on sections really quick here. So section 3B, the Medicaid eligibility expansion, technical analysis. All of the technical analysis, we are supportive of the intention here. We're supportive of the mission. For most of this, we see this as being very achievable. I will flag the rate reimbursement study as an area that would require quite a bit more work. I would like to have Alicia come back in and speak with you all at some point, so that we can have a little bit more of a robust conversation on that. But we certainly support certain sections, but we have concerns that are that we have no means of determining the average reimbursement rate at this time, and we have some other concerns that we would require quite a bit of resources to accomplish that.
Okay.
We don't have much else on the other technical analysis portions, but I would flag that the effective date may be of some concern to us. I'm not sure if that's going to be feasible from our end, and we're doing more investigating on that front to see if that's something we can do with the effective date as written.
So can I ask, one thing to think about on that to come back with is one of the studies in here is for the merge market, which there is a tight timeline on that because if the subsidies go away, we need to make some decisions early next year. So if we need to have that be a separate effective date, that's, I just want to flag that.
Yes, we absolutely hear and agree with that. It's important to address the subsidy expiration. I would also flag in that section in D2, sorry, I'm trying to read our notes and find it in the thing here. There is a technical fix needed that it should read enhanced premium subsidies instead of cost sharing.
Can you say what page you're on? I'm sorry.
I'm trying to find it right now. It's 11.
Mine's 5.
Federal enhanced cost sharing subsidies.
Yeah, no, you didn't say that. Did you say?
No, I'm sorry. I'm not sure that's correct. So this is in section 3D, the marketplace and affordability study. Sorry,
That's okay.
I can't flag this with Ledge Council, but I'm having a connection issue right now. I'm not able to pull up. the
Yeah, we're having a lot of that around today.
So I do apologize. For that. I will provide that information in
Okay.
follow-up.
That's fine.
But it's a quick language
Okay.
change.
Let's get it. Great.
Absolutely. We're unlikely to have a full analysis on the public option by the due date for that study, but that is the right due date to address the subsidy issue, and we acknowledge that.
Okay.
We want to make sure that that happens. So just to note on the study appropriation, we originally estimated this cost for the study for the expansion and marketplace only. So we would need to do more investigating and make sure that that's the correct number that we're getting for you guys.
Okay.
We're currently working on that.
Okay.
The curb piece, I'm gonna let Sandy come in and talk to you guys about that, because I do think that's a conversation that she'd like to spearhead. But we're certainly appreciative of your guys' willingness to work with us on that, and we very much support the intent of transparency and collaboration there with the curb. again, and I'm sorry to back up, the Global Commitment Fund section, we are reviewing that currently, so we'll have any notes on that, but I
Okay.
believe that the changes that we recommended have been
Yes,
incorporated.
they have been, but.
So I think that from our perspective should be good. I'm not going to touch on the MSP expansion in this conversation because I know you guys are probably have had your fill of that today already. If there are, and we will certainly provide additional information and follow-ups in that discussion. Again, as I mentioned, the effective dates, we're not sure that those are going to be feasible for us. So we're just kind of, we're like to flag that as a point of conversation, and we're going to review on our end to see what we can do.
Okay.
From a high level perspective, we appreciate all the work and discussion that's gone into this bill. We support the mission here, and certainly, obviously, the caveat of appropriation notwithstanding, we love what we're seeing here, and we want to be supportive and help as much as we can.
Great.
So appreciate you taking the time to speak with us today, and I'm happy to answer any questions I can at the moment, but I'm also happy to take these questions back to Diva and get you really nice detailed answers.
Perfect. I was gonna say Alex, Art, and then Alyssa.
My brother Val.
Oh, Al, there you go.
Absolutely. Are you saying the 350K of appropriation may not be enough? Is that what you're kind of saying? Is that the appropriation?
I think we want to ensure that we're asking for an appropriate amount.
Gotcha.
We don't
Okay.
want to be asking for less than we need.
Gotcha. Absolutely.
The rate piece in particular, I think, is a bigger lift
Right.
than what we'd originally envisioned in the
Yeah.
technical analysis. And so we would need to look at what we'd require for that.
Gotcha.
Alyssa?
I just wanted to ask the question I had asked Jen, which is there provider types? Was there a reason like skilled nursing?
Well, so Diva didn't put those in,
Okay. Are there?
but you could
rate-
answer to, could skilled nursing be part of this?
I can answer to direct you to Dale, because skilled nursing facilities falls within Dale, and I can direct you also in the designated agency to DMH. They're going to be better positioned to answer that than we are.
And there is a reason. I just don't remember what it is. So
Okay.
I promise, we'll get you an answer.
Okay. Yeah. As long as there's a reason.
Yeah. Anyone else? Questions? Listen.
Yeah, my question's similar. You talk about in this list, and I'm not sure where this list
The
comes from.
list did not come from Diva, so I just, the list
Okay,
came
yeah.
from other advocates in the room.
Okay, so I'm gonna be an advocate for step outside one role, for palliative care, including adults, to include adults into palliative care.
So we're gonna not direct that at Diva. We're gonna direct that at the appropriate association that will come forward and be able to answer that. Because Diva's just doing the analysis. I don't know, we're gonna ask the question to everyone that comes up, and then someone will be able to answer it.
Great. I love
And if
it.
not, they'll tell us who can.
I love a plan.
Okay. Anyone else? Great, thank you.
Thank you.
All right. Is Sigma coming? Jessa. Is Jessa here?
Yeah, right there.
Hi. How are you?
Doing well.
Thank you so much for having me. Jessa Barnard with the Vermont Medical Society, representing physicians and PAs and largely focusing on the professional fee schedule pieces I talked to you about under the RVS fee schedule. But just to start out more generally, I want to thank the committee for going in this direction with the bill. We really appreciate taking the time to make sure this is done well and done right. I know there would probably be some frustration to not see more immediate expansion of comprehensive affordable coverage that Medicaid provides. So we appreciate the sort of step back to say we really need to understand and have the technical analysis to know the impacts before coverage starts. So thank you for that. We, in particular, suggested some of the language and support the language starting at the bottom of page 7 in C1. So that is the technical analysis of reimbursement, because we really do think that, if there, especially if, again, depends which of these categories and how much of an expansion would take place, but providers really need to understand the impact of that. And I appreciate what Diva is saying. Some of it is a bit of a complex analysis of are these people who have been uninsured or on commercial coverage or already on, other, coverage. So to the extent we are able to gather as much of that data as possible, that will be really helpful for providers to understand the impact. And then that feeds into, well, what is the right or an appropriate reimbursement rate for those newly covered individuals under this program. So we appreciate taking the time to gather the information about how this will impact not only patients who would gain this coverage, but also provider sustainability. I had a small suggestion of language, sort of seeing everything come together and the definition of which providers are included. A small comment on page 8 in CE, little c, big letter E, and now I need to get to my right page here. There is a reference in that paragraph to, this is where, and actually there were some questions about this earlier, comparing to 125, 145, 160% of Medicare rates. So again, using Medicare as a benchmark. And then it has that clause with both primary care and specialty care services reimbursed under the RBRVS fee schedule. Open to conversations around this. I'm thinking it may be more appropriate to actually add that reference to include primary care and specialty care services in that final definition of all of those rates that are being looked at, because this is an unusual fee schedule, I think, for DIVA, and that it's kind of split up. So it's the professional services, but then they have a higher amount under that, sort of a factor, they increase it for primary care compared to specialty care services. So I think we would prefer, our preference would be on page 10, where it then defines provider types and lists sort of all the reimbursement methodologies, to say there professional services reimbursed based on the RBRVS fee schedule for both primary care and specialty care services. So you could add that, we want to look at both primary care and specialty in one place where you're talking about that fee schedule. Right now, it sort of seems a little odd to tack that on, when really I think you want to do that analysis of the 125, 45, 60 for all the provider types you then define down below in that section C2. We very much support and appreciate the language on middle of page 9 in H. So that's saying if rate differentials do continue between primary care and specialty care, please look at include what it would cost, or including prenatal, labor and delivery, postpartum, and psychiatric care services under the enhanced primary care rate. We actually just got a comment this morning from the American College of Obstetricians and Gynecologists saying, we saw the first draft of this bill, can there be a look at including OB care in primary care? And I said, great, we've already talked to the committee about that, and that's in this new draft. So I will mention support for that. So thank you for taking a look at that. Those are such important access points for Vermonters to care. And regardless of expanded coverage, we think it actually would be important for DIVA to take a look at including those services under that enhanced primary care payment rate. So those were all the comments I prepared. We really support this direction of this draft and the language with that one little suggestion. We appreciate the committee and those really interested in this work, so taking the time to do this analysis. Yeah. I will add, I think this is clear, but a couple people have mentioned this to me in looking at this draft, so I'll just put it out for the committee to ponder. The question where it says some of the, let me see if I can, actually, this is up actually under the expanded populations, page 7, under those residents up to age 21, looking at expanding, or the feasibility of expanding coverage as soon as reasonably practicable. I read that to still mean after we still do all the analysis on the provider reimbursement as well. So we're still looking at kind of it together, but a couple folks did ask me how did that work with that timing of as soon as practicable? Would that still be informed by kind of the rate analysis? I think given the timing of when you've asked for the report back, it probably would, but especially if you're looking at implementation dates and kind of how things would be sequentially, that's just a comment to put out there.
Can I ask clarification on that?
Yeah.
So whether you or others who have talked to you, is the concern that we would go to 21 before any rate adjustments are
Correct.
made?
Exactly.
Okay. So even it's only 1,800 youth who could potentially would be moving over, you would rather see the rates, understand the rate increase, not increase the population without a rate.
Right. Our preference would be to kind of do it at the same time, understanding, again, and that was actually, we just heard this morning, sort of those numbers, so we didn't even know that before.
Right.
So you're right, it's not a huge number of people, but I guess just clarity, kind of one way or the other would be helpful, so people know, could that be before or not, looking at rate. But we already are gathering some of that analysis. I think that Dave already presented some of that this morning, so that's helpful.
Anyone else have questions? You want to ask your question, Leslie?
Oh, is this where it comes?
Well, I don't know. We're going to ask everyone.
So on page 10, there's a list of provider type categories, and it says pediatric palliative care does not include adult. And I was hoping to include adult.
That, can I keep phoning a friend? We'll just keep that. I'm not positive about that. That could be the VNAs who provide those services. I think pediatric and adult may be different fee schedules.
Yeah.
I'm not the expert on that. That's just what's coming to mind. So that may be why this is the only one put in this bill, but Joe Olson with VNAs would probably be the right person.
But I would love to find a way to expand it, even if there is some kind of technical, who knows what.
Why don't you reach out directly to Jill, because she is not on the schedule today, nor she is here. So if you want to email her, that'd be great. Okay, thanks, Jessica. Hey, Kate? It really does feel like a hot seat.
All right. So hi, thank you, everyone. Mary Kate Molman with By State Primary Care Association. We are representing and supporting FQHCs in Vermont. Generally with this bill, we are supportive. We think it's great, any effort that expands eligibility, expands access. We 100% support that is fully aligned with our mission and our goals and working with our communities. The one part that I will focus on is page 9, line 16. This is J under section, let's see, 1. So this, I just want to go over again. FQHCs are paid an encounter rate for like a per visit rate, and that visit could be as simple as a wellness visit, or it could include services like an eye exam, general wellness, office visit, SUD screening, depression screening, medical nutrition evaluation. It could include a number of different services. And this type of payment is for both Medicare. Medicare has their own set of rates. We call them PPS, and then Medicaid has its own set of PPS rates. The Medicare covers a much more limited number of services. So that rate currently is lower than our Medicaid rate just because it's more limited in the scope of services that it covers. So the language in here of percentage greater than 100% really wouldn't do anything. You start to, based on our current rates, you start to see an impact of this as a floor at around 112, 115% of the Medicare. And that really just brings up, that would really impact our lowest paid FQHC.
Do you have a suggestion as to what to put? Or do you want to get back to us?
I'm happy, I would say, put it maybe a minimum of the 112. Sorry, God, Vision went skydiving after 40. So I would say like a 112, but then maybe part of the technical analysis, looking at a range of what is the fiscal impact. Again, we want to be respectful, but it's nice having that minimum.
So 112 is the floor. Or do you want to get back to 115? Okay. All right, and then do you think language is needed in the reimbursement rate technical analysis to get to? You're asking.
I would say, so the idea here is that this sets it up as the like benchmarking to Medicare as a floor. This doesn't impact our Medicaid PPS requirements. So if the PPS rate is determined, our federally required minimum is for a specific health center is higher than this floor, then that's what they should be getting. So that's where I would say the analysis could look at a range to figure out where that floor is most appropriate. But it doesn't, that's as far as I would suggest. All right. Any questions? Thank you.
And welcome back.
Hi, Devin Green from Buzz. And really appreciate the committee's work on this bill and all the attention and detail to the provider reimbursement piece. As always, Buzz supports increasing access to care. We think there are a lot of good things that could come out of this effort, including potentially drawing down our uncompensated care. So it's a balance between reimbursement and impact on uncompensated care. And I think the couple of things I'd like to touch on today, and then come back with more if needed, just to run this language by some other folks. Hospitals do provide palliative care, Representative Goldman. So I think we'd be in support at looking at the adult piece there. And then the other big piece is the pregnant individuals. As Jessa was saying, she has concerns with the children. I have talked about this before. We have concerns with birthing services and the ability to keep birthing units open, and we want to make sure that they're reimbursed properly. So we would ask for that to be vetted before put into place.
Where are we, Devin, in the bill?
That is a great question. I think so. The expanding, yeah, page 7, number 4, line 8.
Okay, so sorry. I was thinking you were talking about something different. So tie the Medicaid rates, reimbursement study, do that before we would
Expand the eligibility. And to us, the importance of that is greater than the children's eligibility because of the position that birthing centers are in.
Everyone understand that?
Oh, I do not.
So the concern is that if we, this morning when Diva was here, we had some cost estimates of expanding individuals who are pregnant from 200 something to 317. And then we also had the discussion of expanding youth to 20. So both of those things, if we had the money and if we passed the bill, we could actually do fairly quickly. That's allowed in our state plan. So, but what Roz is saying for one of them and what VMS is saying for the other is if we expand that population without also giving provider rate increases for Medicaid, providers would be seeing more patients at a cost
Less,
yeah.
they'd be losing money more.
Yeah.
So that means what? That means,
It's a policy decision on what we would do.
okay, it's just, this is information for us.
For us to think about and come back and talk about.
Gotcha.
So it says to all pregnant individual incomes that have below 317%. Now, is that the individual or is that going to be a family?
You know, the individual, the woman who's.
So an individual.
Person.
Okay.
Yeah, and right now it goes to 2 something.
Right.
2.7 or I don't know, 2 something. So we would do what?
208, 213.
Okay.
Yeah, so we would expand that population.
Yeah.
And that's all I have for now.
Anyone have any other questions for Jen? Okay,
Thank you.
thank you. The insurers couldn't be here today. And this obviously will be coming back to this. So we have some time, so I guess just thoughts, comments.
So we have time. I don't feel bad suggesting this. I don't.
Can't wait.
I was making you wait. So I looked at the 141-page bill that was Act 48. Many pieces of which are in current state law.
I think it's okay if you would just remind everyone what Act 48.
Act 48 was passed in 2011, and it attempted to create a universal healthcare system in Vermont. And as part of that, it laid out principles in law that are still on the books technically. I didn't read it in great detail because I was also listening to people, but I was reading, looking for certain pieces. But what I was doing, the reason I was doing it is I was comparing this to Act 48, like evaluating it in that context. And there's principles in Act 48 that we'll put into law to kind of guide us towards having a better healthcare system. So I was wondering if I could read them because they're not that many. And then people could think about, is there anything, does this bill do enough in that regard? I know there's some things we can't do, but there's a lot we can and have done. And so I don't know, let's, okay. Rewinding. Okay. It's very long.
Maybe we can, and that is just, yeah,
Well, no, I found it. I was just
Okay.
rewinding.
there's like 10.
Yeah, but I was like at page 100 and
Okay.
I stopped because I was listening, but then I was like, okay, I don't need to keep looking at this.
So you're just reading the
The principles, yeah.
Okay, go ahead. Which we used to have
On the wall.
pre-COVID on
so I
the
wouldn't-
wall,
yeah.
yeah.
Maybe maybe David Sheets has them hidden in some closet. We can put them back up. If the mold didn't get them.
Yeah,
The
the-
frame downstairs on the side.
The mold got them.
In
The mold got them?
Yeah.
It's symbolic. So the state of Vermont must ensure universal access to and coverage for high-quality medically necessary health services for all Vermonters. Systemic barriers such as cost must not prevent people from accessing necessary health care. All Vermonters must receive affordable and appropriate health care at the appropriate time in the appropriate setting. Overall, that was one. Overall healthcare costs must be contained, and growth in healthcare spending in Vermont must balance the needs of the healthcare needs of the population with the ability to pay for such care. 3, the healthcare system must be transparent in design, efficient in operation, and accountable to the people it serves. The state must ensure public participation in the design, implementation, evaluation, and accountability mechanisms of the healthcare system. 4, primary care must be preserved and enhanced so that Vermonters have care available to them, preferably within their own communities. Other aspects, I'm not going to read this whole one, not to be rude. It just lists a lot of stuff. Basically, it's the
Focus
first
on
sentence.
primary.
Yeah, it gets into the details. There's an ellipsis there. And we'll skip to number 5. No, I was just making that up because that's the word they use when they write. It was
Keep going,
it was
keep
a bad law joke. All right, number 5. Every Vermonter should be able to choose his or her healthcare or their healthcare. Vermonters, I'm adding that in. Vermonters should be aware of the costs of the health services they receive. Costs should be transparent and easy to understand. Number 7, individuals have a personal responsibility to maintain their own health and to use health resources wisely, and all individuals should have a financial stake in the health services they receive. I knew you were going to like that one. The health care system, see, it isn't all that bad, the universal healthcare law. Number 8, the health care system must recognize the primacy of the relationship between patients and their healthcare practitioners, respecting the professional judgment of healthcare practitioners and the informed decisions of patients. Number 9, almost there.
That's fine, you're doing good.
Vermont's health delivery system must seek continuous improvement of healthcare quality and safety and of the health of the population and promote healthy lifestyles. The system therefore must be evaluated regularly for improvements in access, quality, and cost containment. Number 10, Vermont's healthcare system must include mechanisms for containing all system costs and eliminating unnecessary expenditures, including by reducing administrative costs and by reducing costs that do not contribute to efficient, high-quality health services or improve health outcomes. Efforts to reduce overall healthcare costs should identify sources of excess cost growth. There's a few more. We're almost there. Number 11, the financing of healthcare in Vermont must be sufficient, fair, predictable, transparent, sustainable, and shared equitably. Number 12, the system must consider the effects of payment reform on individuals and on healthcare professionals and suppliers. It must enable healthcare professionals to provide on a solvent basis effective and efficient health services that are in the public interest. Number 13, Vermont's healthcare system must operate as a partnership between consumers, employers, healthcare professionals, hospitals, and the state and federal government. And last but not least, number 14, state government must ensure that the healthcare system satisfies the principles expressed in this section. So I just thought, like, hearing them and I looked at the bill and I think it actually does in some ways take us closer to meeting these principles. Because none of these principles say there must be a universal healthcare system. That was in the intent that came before them. But because the intent says it's the intent to create Green Mountain Care to contain costs and to provide as a public good, comprehensive, affordable, high quality, publicly financed healthcare coverage. And it goes on. But the principles, I mean, so we're not achieving the intent, but I guess, and I know that that's going to be hard to do in this bill, but I was kind of hoping we would take a moment to think about, you know, how we're supporting those principles and is there anything else we could do? And maybe there isn't, but I wanted to, since we had the time.
Well, I think that was good because
Okay.
like I said, when I first came here, they were on the wall. So it was always good to have in front of us. And I think, you know, we can all agree we're really falling short in a lot of areas. I think this session has really pointed that out even more. Art?
Well, we are, but the system is so complex. When you look at the complexity of what we deal with.
Yeah.
I mean, trying to break it down and to change it, just to breaking it down.
Right, it's very
Would
hard.
be, I mean, it would be like throwing a bomb into the,
Right.
it would be so difficult to just to start.
It's very, and I think that's why we haven't gone
Right, I
very
mean,
far since 2000, whatever. it
Who
is.
would even have the knowledge to start the thing because it's just so big.
And we're very tied to the federal rules, which doesn't help. You know, I think we would all agree, if we were starting this from scratch, it would be very different. So Leslie and then Alyssa.
Well, getting back to first principles, I think that it's important, but also our principles, I think principle 6 really does look at what this bill is.
Adjusting barriers to accessibility, affordability, sustainability, and efficiency across the health system.
So I think that's current. That's theoretically what we've agreed to. And this bill addresses that.
Listen.
Mine doesn't relate to this discussion. It's a really great discussion though, and I didn't want to interrupt anybody else if they had
All
a
right.
question first.
Any question on,
Or
anything
comment.
else on this?
I just really appreciated
Yeah.
me reading that, Brian. I've never heard that. So really like the framing of it, and then also just like having guiding principles helps because I feel like it's never going to be easy to do this work, but it is so essential. And so I'm really thankful for it this moment.
I'll send them an email to everyone as a reminder.
That'd be great.
Maybe we can have them up again in maybe more creative fashion.
All right, Alyssa?
Thank you for the reminder of those though, because you were reading a couple of them and I thought, that's what we're trying to do there.
Yeah, exactly. That's what I was hoping we would
Yeah,
see.
in different bills. No, I wanted to, you know, because we had the discussion this morning around expanding Dr. Dinosaur to pregnant to get it up to the same level that children are currently at under Dr. Dinosaur. And to the same point of, can we expand those populations before we do a cost analysis? And I'm just throwing this question out here. I don't need an answer right this minute. But is the disparity currently between the payment rates so great in those two categories that it it's not made up for in currently uncompensated care within this population,
those two
these two populations. I mean, if I'm thinking about 19 and 20-year-olds, I'm guessing they're not big bill payers and, you know, I mean, is taking the Medicaid rate better than what you're kind of getting right now in this population? And the same with the out-of-pocket costs for somebody in this income who happens to be pregnant. Is that disparity in the payment rate so great that we're really looking at an onerous? I mean, are we gonna put birthing centers out of business because?
Yeah, Debbie Green, I do wanna think about that more, I think it's a good, I think my concern is that birthing centers are really struggling, and so that's where it feels like the young people thing can be absorbed a lot more easily. I'm cautious about the birthing centers, and so I will try to get more information on that and come back.
I'm just worried that this is an underinsured population currently. And we're not taking into account uncompensated care.
Leslie?
I just want to support you on that. I was thinking the exact same thing as I was reading it. It was like 1,800 people. I don't know how much in the birthing center realm across the whole state. So it will be spread out, and it, as an individual, on an individual basis, it could be really important for the 18 and 19 to 20-year-olds. So I'm hoping that we can look at that and have it come ahead of the whole analysis, which could delay it for years. I mean, you know what happens when we get an analysis and then it sits around and da, 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 da. So we can do at least something small for this population now.
Anything else? Anything about thoughts on what we talked about this morning with the Medicare savings program?
Oh, yeah, I have those.
Brian and then Alyssa?
I think that the policy decision to draw down, to invest more state money in a way that draws down more federal money, but frees up money that people really don't have to spend on healthcare or be forced to spend or to forego healthcare. I think that policy decision is very wise. If I think about like the relief it could give thousands and thousands and thousands of people who are struggling, that reduction of their financial stress is going to have a positive health impact, because financial stress has such a huge impact on our mental and physical health. So the benefit is not only economic, but it's also social. And I think that it's hard to measure that, but there's a lot of public health research that shows that policy decision would impact more than one social determinant of health. It would increase access to healthcare. It would reduce financial stress. I could go through a list and read many other things. So as a policy decision, I think we should aim high. And I'm happy to brainstorm ideas about how to find that extra 15 million or whatever it would take. But we have a committee who specializes in that. And there are methods out there. I threw one out there earlier that I was just kind of making up on the fly about maybe we tax people who pay the least for their insurance a little bit more to supplement those who don't have money to pay for their prescriptions, And so, but I also learned that there's a claims tax that is charged to insurers. It's a small amount, and that increasing it even a little bit can generate a massive amount of money. And so that's not our job, it's Ways and Means. So I would suggest that we aim high and we go for, like, I think it was option 1, and try to help as many people as possible, and then have faith in Ways and Means that through their deliberative process, they can come up with a pragmatic and fair way to fund it. I think that's all I have to say about that. I tried to keep it short.
so we're gonna go with Alyssa and then Alan and then Leslie.
But I feel very strongly about this, which doesn't matter, but I mean, to Brian's point is, I think we should start this policy forward. I can't think of, I mean, we hear about so many areas, we care about all these areas, but I just keep coming back to, I mean, look over at this chart. And can you imagine what it must be like to make $20,000 a year? And it's like $1,700 a month. And you're living off of that. And you're on Medicaid, and then now all of a sudden, you have to pay almost close to $200 a month in a premium, in a supplement, in prescription drug plan, in the out-of-pocket costs. I mean, where do you get that from? I mean, how do you, I can't imagine like how you would survive on that and how you would not live in fear. Like live in fear of something happening. And I mean, of any population that if you want to think about expanding care to, I can't think of any population more in need than this population. And what it would be transformative for these people. Would be transformative. I mean, this is the kind of thing that it can change your life. To just not have that hanging over your head. I can't imagine what it must be like. And it seems like it's I know it's a big dollar, but it seems like such a small dollar amount to invest in the people that need it the most. I say go big. I'm sorry.
Bigger, go home.
He's crying.
First tears we've had all session.
No, I don't, I've held it in some that you didn't have.
Okay.
I hate to follow that. Well, and she's right, okay, the speaker just then was right. But, you know what, we don't know the unintended consequences of this. I think yesterday, the Medicare savings plan is great. I think there's.
That's what we're focused on right now.
Okay.
That's what we're talking about right now, but you can talk about the whole thing.
Well, I thought it was an open conversation.
It is, absolutely.
All the rest, the people that you're saying that most need, you come up to Franklin County and these people that are just about surviving are the ones we're asking to pay for this.
No.
Huh? But any way you want to look at it, there's cost to everything we do here. That there's a cost, and if it comes from the general fund, where does that come from? So that's concerns of mine. We've got a lot of people that we're asking to help that probably going to be in that same category down the road.
If I could just, if you could just be more specific in terms of people in Franklin County that we're trying to help, would be the ones that we're paying for.
We would help a lot of those. There's also other people who pay taxes up there that are underinsured already. They're not making that much money over the poverty level, so they're not, and they, you know, these same people are looking at 26% taxes coming up to survive in their villages and towns and school. So, you know, yes, it's nice to help that, but we're gonna have a lot more in that category down the road.
I'm not saying, I'm not disagreeing with you, right? There is a cost to this. This bill, unless we, fund certain things, the overall intent of the bill is to study the situation. So we have the data in front of the next body that's here. But I would also say that, some of those people, a lot of those people would be the people who would now be covered by Medicaid and would have they might have to pay a little bit more in tax, but they're getting on Medicaid as their insurance company, and there's probably a cost benefit there. So, but again, to your point, and it's something that would help us understand.
I understand that.
Yes.
The unintended consequences, it's going to cost the public money.
Yes, it is.
It
It would cost.
absolutely is, Penny.
Yes.
It's gonna cost money, to certain portion of the population. But since I've had a discussion with Penny about this before, I'm trying to figure out the people that you're talking about that are gonna get whacked by this. And I'm thinking, instead of paying $1,700 a month or whatever the monthly premium is that they're paying now, they would be on a Medicaid program instead.
I do understand.
And I'm trying to figure out, are they going to be better off or are they not going to be better off? In my opinion, the ones that I think you're talking about are going to be better off. The people that have a little bit more money, they be able to contribute, they're gonna get hit a little bit.
They're right. But, you know, I don't know. I just think, listen, we heard this morning about our home health agency.
Mhm.
We're closing up there, or we're going to. Somebody just called us out, which was right on us, okay? Because everything is being used extensively. And you're still asking, you know, our town tax and all this, 26.7% to help pay for that. It hits you somewhere. Might not directly hit you on your insurance premium, but it's gonna hit your community.
Leslie? I'm good, thank you. All right. Melanie, and then
I
Art?
just want to say that I fully support doing more of the studies and being able to understand all of the inputs and repercussions as much as we can and doing that due diligence. And I understand that we need to do this. I'm also so thankful that there's still the provisions in here to look at how we can help with Medicaid savings plan. This morning, I kid you not, I got a call from someone in my community that said, I'm over $18. My wife and I are now knocked out. We're on the cliff and we've just fallen off of it. And what can you do? And I heard that you're doing this bill. And so today coming in, I was sitting here, Claire and I were in here, I said, you're not gonna make a call? And I'm talking to him and I'm thinking of him as we're doing this. And so I hope that we can continue this work because it's so necessary and it will help people immediately. They won't be putting their groceries on a credit card. They'll be getting healthcare. And the fact that there's federal monies that can be brought down, and the fact that we have some time to plan and to think about it for FY26, I'm excited about it and really thankful for this.
Art?
Yeah, a couple things from my perspective. I wish this piece was in a separate bill, first of all. I don't know if that's possible to do. But to me, this section needs to come out and be its own separate thing, because I think it's, other than the $350K for the study, I don't think there's any other appropriation in the bill.
No, not unless we choose to fund something.
Right.
Yes.
right. So
So
that,
what piece do you want out? You want the MSP piece out?
yeah,
Okay.
yeah. The other part is on, I have a couple things to say, but
Good.
yeah, no, on the fiscal impact of this. Now, we heard some of it, but is there going to be a fiscal study to get the joint fiscal office's impact of that?
Of the medical savings
Yeah, right.
program?
I assume we'll want one, something official.
Probably.
Yeah, okay, so we know the exact numbers that we're talking about. And the last thing I will say, and this is probably a fault of mine, I have trouble with compassion, I have to tell you. I hear what Alyssa says, and she's probably very right. But I just think we give away too much. I think we give away too much, and I think we create dependency when we do, and that's half our problem. I think our goal should be get as many people as we can off of Medicaid, find employment, have better jobs, push people to find a way themselves. I just rebel against what we do sometimes when it comes to this. And I get it. I get that there's people that suffer, but it just is hard for me because at age 65, you've lived enough life to know you got this face in you. You gotta know by then that, I mean, do a little research, find out, I don't know, do something before that so you're not in a situation. I keep coming back to that. It's probably a personal failing, but, and I'm not saying I won't go with it, but it's something I really, really struggle with. I believe in personal responsibility, and it just is hard for me. Give away, give away, give away, give away. It's what we're doing. So that's my 2 cents.
So can I ask a clarifying question? You want the MSP pulled out to vote on that separately than this piece of it.
Right.
But the piece you're saying where, well, actually, I don't have a clarifying question. I think I know. I'm good.
Okay.
I think what might be helpful, and I'll see if we can do this, is bring in some folks on the MSP part to talk about truly the population we are talking about with that program. Because as Mike alluded to, the healthcare advocate alluded to earlier, it's a lot of potentially single women who are over 65, who raised their children, so didn't have the Social Security income, now for whatever reason are not married, and they're really struggling. So I think it would be helpful maybe if we come back to that with some testimony for that piece of it.
Could I say something else too?
Yeah.
The folks that are truly disabled, I don't know why we require them to pay 1 nickel toward their Medicare. I think they should get a free pass till the end of their life. If you're in a wheelchair, you're just disabled, can't do anything. Boy, I can't imagine making that person pay a nickel, but.
There's some that has there.
That's a lot of.
But here's the caveat. People that, you know, we had this discussion out playing golf and oh, I'm disabled. Well, if you're playing golf, you're not. And people can say they're disabled. So there's always the rest of the story.
A whole lot of.
I know. And so what's disabled mean? And you know what I'm saying?
Yeah.
I know. So. Yeah.
Right.
So I wasn't gonna say anything, but I think I still want to say something. We spend so much time in this committee and this is my 6th year here, hearing the almost infinite ways that people that live in Vermont are, I think, in many ways victims to our messed up healthcare system. And how we, as a small state with limited resources, we in this committee, other committees of jurisdiction try so hard listening to all of these life experiences from people who are living with the results of a messed up healthcare system. They are victims of it. It's not, to me, respectfully, Art, it's not an issue of personal responsibility. And we have, I have been joking lately about wanting to put a fairly soft cushion on the wall with a sign over it that says "bang head here," because the kind of decisions that we're faced with. This is one decision, like Alyssa said, where we can have a dramatic impact, the MSP, a dramatic impact with relatively low cost. I mean, this is, I think there have been very few situations where I personally have experienced this in this committee, where we're going to be able to help so much more than we usually can.
If no one else.
Well, let's see. Bobby, did you have
I
some?
don't know, I feel like this is getting really deep and like philosophical all of a sudden. But I mean, just a little background to reflect on what I've been hearing here. I mean, I grew up in a family where everybody worked and I literally lied about my age so I could get a job at 14, you know, because I was just like, that was what we did. And we had a lot of family and we all relied on each other. So if somebody was suffering, the rest of us picked up the slack and held them up. I didn't even know what something like a trust fund was until I got to college. And then, so I hear about dependency and people getting stuff for free. And I was amazed at how many people, it's not the majority of us, but you know, never had to work for anything in their life. And it's not government benefits, they're getting an inheritance. And I consider that to create a kind of toxic dependency that's worse than something that comes from someone who is poor. And has struggled and works really hard and still can't pay their bills. I can't weigh those things equally. And so, you know, I think we end up paying for it anyway. It's hard for me to hear, we can't afford this, like as a society. You know, in my town, there are second homes that are multi-million-dollar McMansions that people live in for 6 weeks of the year, and then they're empty. So it's like, we can't afford to pay for this. I'm like, really? You know, that's kind of my philosophy. Where there is money, and some people have a lot of it, and many of us have none of it. You know, so that's kind of when I hear about this and what it would cost for us to give this to people seems minuscule compared to, you know, what people waste on first class tickets, you know, instead of riding coach. So that's kind of how I feel about it.
Brian and then Melissa.
Daisy didn't go yet. Do you want to go first?
No. Oh, I'm sorry.
Okay. No, I was just being mindful
I'm
myself.
sorry.
She didn't raise her hand though. I was
Okay.
just making space because I said the thing in the beginning. I want to go back to what you were saying, Penny, because I was thinking about like the unintended consequences, and we are doing a fiscal analysis, so we'll know more before we make those decisions. But I'll just be honest, like I was looking at this chart and realizing that if we go up to 317%, I might be able to get Medicaid. And I was like, oh, that would be such a relief. But then I had my heart dropped because I'm like, what if I make a little bit too much and it's 318%? Because I've been through that. I was on Medicaid and then all of a sudden I went on to private insurance. It was hundreds more a month. And now I pay $730 a month for something. They were the $10,000 deductible. And like, I'm afraid I owe $150 from having COVID. I got a $1,000 medication for free because someone gave it to me. But like, I'm happy we're doing this, but there's this piece that we're still not getting is what about the people who make 318%? And like when we take people out of the risk pool of insurance companies, they've told us that those premiums are going to go higher. So is it going to be like $2,000 a month for health insurance if you don't get Medicaid? So I still think we should do that, the fiscal analysis, and move forward. But until we find a way to include everyone, there's always going to be people who lose. Yeah, and so I just want to acknowledge.
I had a farmer call me, I think some of you heard the story. He's probably 22 legal Mexicans, okay? They're all documented. Government comes in once every other month, talks to them all, everything's legit, okay? They send 60% of their paycheck home.
They also pay taxes.
They pay taxes, but they don't have insurance and they meet qualifications for this. Well, maybe not for this certain insurance, but some of the families do because there's families of 4, there's families. So the thing is, they get a lot of the programs that are offered through the state. But then you got other people at home seeing this and they're saying, no, God, they're sending all their, they're asking Vermonters to pay for what they send home.
So what they
There's some
send
truth to that.
home has nothing to do with what they're eligible for. What they're eligible for is based on their income and they pay taxes. So if they're eligible because of their income, they have the right to the same benefit as the rest of us. And they're choosing, instead of potentially saving money or putting food on the table, to send some money home.
Or buying insurance and then when.
If they're eligible based on their income for Medicaid.
Okay, but they're still not buying insurance at home. This is why our home health agencies was going to close, because the ambulance service is being used all the time with these people with no income.
And that is our fault, because we do not do the reimbursement rates appropriately to pay for those services. But I just want to be clear, if someone is here, everything is based on their income, whatever they might be eligible for, just like people are eligible for Social Security and other benefits. And it is their choice on if they want to do something else. But if they are eligible for Medicaid based on their income, that's the only
So
thing
what
that
happens,
matters.
and the same farmer told me, I offer insurance. It's about $40-something a month per person. So $200, and he said, my share is more than this. They do not want it because they want that cash. But if they're sick, they can still go to the hospital and get all the same care as other people.
So I think you and I need to sit down and dig into that, because there's a lot there that I think you and the farmer and me as chair of healthcare would need to understand. Yes, and I would be.
I bet you come in and talk.
I would love to do that. Alyssa.
So at the risk of getting personal, and I want to respond to my dear, dear friend Art. And he is a dear friend.
I'm gonna make sure we're sticking to the bill.
I know,
So if you're not sticking to the bill, then.
I am sticking to the bill. I'm sticking to the bill and the eligibility and the people that we're talking about here. I want to make sure that everyone understands that when you're talking about this population, you're talking about people like me. I've worked since I was 12 years old, my first job tying grapes. And other than 3 6-week maternity leaves, I've worked every day of my life, sometimes 2 jobs. I'm working 2 jobs now. I know what my Social Security benefits are going to be. And my Social Security benefits, if I was to retire, I would be living about the level that we're talking about here. Which, by the way, means I will never retire. I will probably work until the day I die. But I want to make sure that when we say things like people shouldn't be handed something and that, people should work and people should do that. I want you to know you're talking about people like me.
Okay, I think on that note, we are gonna be done. So, good conversation. I think what I'm hearing in mixed ways is that we're gonna keep having this conversation. I'll work with Diva as they work through the specifics. They hadn't seen this draft before yesterday, and so I know the reimbursement rate stuff was new for them. See what we can do. We'll talk about this key. We have the rest of this week, next week, and then the week after crossover to get the bill out, if we choose to do that. So we have some time. So tomorrow, be prepared, doing budget. We will also do a walkthrough of the Ways and Means Amendment on the peer certification, and if anything comes out of appropriations. And I think that's the plan for all of tomorrow. So if we get done early, we get done early.
Just a quick question. Can we see the spreadsheet before tomorrow?
They're gonna send it. They're sending it to you.
Lori, look at it one more.
Oh, this after.
Yeah.